My name is Phillip Lirk. I'm consultant anesthetist at the University Hospital in Amsterdam. And in my clinical practice, I'm most concerned with patients undergoing visceral surgery and general surgery. And in my research interest revolves around the application of local anesthetics in various forms and for nerve blocks and intravenously. I would define multimodal analgesia as really making an extra effort to tailor analgesia to the individual patient and to the surgery being performed. It is, I think, not polypharmacy. It's not just giving all the drugs to all the patients all the time, but it's a very judicious choosing and selection of drugs for the individual patient for a very specific given procedure. I think the four main reasons to use multimodal analgesia is we can reduce the consumption of opioids, and the consumption of opioids has been linked to the development of chronic pain, to opioid-induced hyperalgesia, and it's also a quite dangerous class of drugs. So if we minimize their use, we can maybe also, that's the second reason, minimize adverse events stemming from morphine use. The third reason is that if we attack pain from multiple sites along the nociceptive pathway, we have a better chance of finally defeating pain or reducing it to a very good level. And the fourth reason is that we spread our pharmacogenomic risks, so patients have different ways of reacting to different drugs based on their genotype. And by giving several drugs at once, we can maybe spread that risk and end up with a good pain relief, even if the patient has a suboptimal response to one of the constituent drugs. So in other words, if we give like 4 or 5 drugs to treat pain, if one of them doesn't work optimally in the patient, it doesn't matter too much because the others will do their job. So I think the 4 reasons are less opiates, less adverse effects, good pain relief, and the spreading of the pharmacogenomic risk. What is certainly true is that by using preventive analgesia and multimodal comprehensive regimens, this has even allowed us to extend our view beyond the immediate postoperative period. So before, with the single interventions, it was very hard to even look beyond the immediate postoperative time, but now with these comprehensive strategies, we are beginning to look maybe a week, 3 months, 6 months, a year out. And in some scenarios, we still see good effects. There are some studies that suggest that the pain relief after surgery may be better, that we have less hyperalgesia at the surgical site. And there are short-term investigations that suggest that after major surgery, mobilization can be achieved faster in a higher percentage of patients when multimodal analgesia is used. My conclusions about the use of ketamine and lidocaine is that both are very, very valuable additions to the repertoire of what the anesthesiologist can offer to his patients. They both have their distinct indications and contraindications, and it's extremely valuable to have them as alternative to the traditional opioid original anesthesia techniques. So for many patients, we can now much more narrowly tailor analgesia to procedure and required and desired endpoints of outcome. So we have just more options to choose from, and I think for some patients it is now first choice. The scenarios where lidocaine can best be used are unequivocally gastrointestinal surgery, like visceral surgery. Here we have seen a very good effect on recovery of bowel function and on recovery, and even on the length of hospital stay as compared to placebo. Not as compared to regional anesthesia, but as compared to placebo. So I think these effects are very convincing and good, have been shown on meta-analysis level and really promote the use of lidocaine. So visceral surgery is definitely the golden indication for lidocaine. Up-and-coming indications include maybe mastectomy, and the results have been more disappointing for orthopedic spinal surgery, maybe with a slight plus, and have been also disappointing for gynecological surgery. For spinal surgery, it has to be said that there is slight positive evidence. So this may still emerge as one of the future indications. And then we would be left with 3 golden indications of visceral, maybe spinal, and maybe mastectomy. These are the three regions where lidocaine use is warranted by the current literature. About ketamine, the use of ketamine, I think it's a general drug that can be used in many different kinds of surgeries. It has shown extremely good results after thoracic surgery. There have been good results in chronic pain patients. There are good results in patients who are opioid tolerant. And this is a drug that maybe has a more broader application than lidocaine. Interestingly, with ketamine is that ketamine also has effects that were not really recognized until recently. For example, a strong anti-inflammatory effect that for decades went unnoticed, but we are beginning to appreciate now that ketamine does more than just decrease pain. It may also affect the body in many other ways that we are not even close to understanding. So this is a very, very interesting and evolving subject. No, so the multimodal analgesia does aim to spread the pharmacogenomic risk across many interventions, but that does not mean that there is a universal protocol that would fit all patients, because patients are different, the pain resulting from different kinds of surgeries is different, and so you still need to tailor to patient and surgery. Your protocol, you need to be prepared to go to plan B, and this could also be an alternative multimodal protocol. It could be regional anesthesia, but so you always need to be in a dynamic process ready to adapt. There is definitely no single project and no single paper or manuscript showing that one size would fit all, and it would also be counterintuitive because surgeries are different and patients are different, and multimodal analgesia is just a repertoire of things to choose from to get the optimal outcome for the patients.